history of TB, no history of any previous surgery or hospitalization. There's no relevant family history. For the past 6 months, patient is on tablet clinidipine 5 milligram at night and tablet Tide Plus with torsemide and spironolactone at morning for the past 6 months. Personal history.
What is Tide?
Sir, 10 mg of torsemide and 25 mg of spironolactone.
Oh, diuretic. Okay.
Yes, sir. Then he quit alcohol 30 years back. He was a known tobacco chewer for the past 10 years and smoked BD for the past 2 years. And that also he quit an year back. On general physical examination, patient is conscious, well-oriented to time, place, and person.
Hold on. Now analyze your history.
Yes, sir.
Somebody has told you have valvular heart disease. Which valvular heart diseases presents with giddiness?
Sir, aortic valve. Left-sided valve.
Aortic valve presents with syncope or angina, yes, or heart failure or palpitation. Giddiness is not a common thing.
Any left-sided valve patients with
supposing this patient walked into your OPD, do you know, first time, without any previous consultation. So how will you go about with a patient with giddiness?
So we'll have to rule out neurological problems and cardiac problems.
What? Neurological problems, okay. What are the causes, common causes for neurological giddiness?
Sir,
your patient is in front of you. You have to rule out neurological problems.
Yes, sir. So it might be a like a transient attack or in all causes of any stroke or tumor. Or just like vasovagal attack.
Okay. What are the other causes of giddiness? Commoner causes.
So this can be even.
What? Come on, girl.
Like so it can be vestibular.
Yes. Okay. You want to look at the ENT causes. All right. Okay. Vestibular. Then
any like so local like any mass or tumor or vascular problems.
That you said already, neurological. Okay, if it is heart disease, valvular, yes, what are all the valves that can cause giddiness?
Sir, mitral stenosis.
Yes, why?
Mitral stenosis with patient having in AF having LA thrombus can lead to cardioembolic.
Okay, thromboembolic phenomenon. Fine. Then
severe aortic stenosis, low cardiac output.
Yes, subendocardial ischemia causing low cardiac output and then causing giddiness. Okay.
Yes, sir.
Giddiness is not a common symptom of AS, right?
Yes,
usually
sir.
Syncope or TIAs, and then first is angina, then syncope, then heart failure, isn't it?
Yes, sir.
Okay. So you must know that, right? You have to rule out, you have to check in your history, you have to check whether he had loss of consciousness, whether he has this thing, is this only one episode, how often the giddiness occurs, then is it related to posture? So you have to rule out neurological and ENT causes of giddiness, and then On examination, you have to look for whether he has got AF, he's got some other problem, the peripheral pulses are lost, all those things, thromboembolic phenomenon. So this is how you have to analyze your history. Okay, so now you have come down to, and you have a history of being seen by some cardiologist, and he was told that he has got a valvular heart disease. So you now come focus on to
Left-sided valvular lesions.
left-sided valvular heart disease. Okay,
Mm.
all right. Now go to
On
general examination.
yeah. On general physical examination, he's conscious, well-oriented, afebrile, moderately built and nourished. There's no pallor, and he's not icteric, no cyanosis, no clubbing, no pedal edema, and no generalized lymphadenopathy. Vital pulse rate is 88 per minute, regular in rhythm, low volume pulse with no radial or radiofemoral delay. All peripheral pulses are palpable. Blood pressure is 108 by 16 millimeter of mercury, measured in right upper limb in sitting position. Respiratory rate is 16 per minute, abdominothoracic type of respiration. Saturation is 99% at room air, and JVP is not raised.
So with this, you have ruled out AF, you have ruled out thromboembolic phenomenon.
Yes, sir.
Yes,
Yes, sir.
regular, but he's got a low volume. What do you mean by low volume pulse? Low volume pulse can happen in MS and in AS also. What is the difference? Why does it occur? Why is it low volume in MS and why is it low volume in AS?
So due to decreased output in AS,
Decreased
so it's low.
decreased preload in MS. So there is less amount of blood coming into the LV, isn't it?
Yes,
So
sir.
the stroke volume is less.
Mm.
And in AS, what happens?
There's decreased forward flow.
And there is something else on the in the pulse in AS. What is that? Classically in AS.
It's diminished with a delayed upstroke.
So what is it called?
This is pulsus parvis heptadis.
You must say that. No, you're now in your final year. You're going to become a consultant in 3-4 months time. So it's a classic. If you say parvus et tardus, that means that or delayed peaking or delayed peaking of the murmur and things like that. The examiner already knows that you're talking about AS. All right.
Okay, so yeah.
So when you are presenting your case, you have to lead your examiner with relevant findings to say that to corroborate your diagnosis. Okay.
Yes, sir.
So ultimately, when you're talking about the diagnosis, you say this patient had parvus et tardus, he had delayed peaking of long murmur with delayed peaking of the stenotic murmur. So all these corroborates to your diagnosis finally. Okay.
Yes, sir.
So in your history only you have to say all these things. You have to highlight these things. Okay.
Cardiovascular system. On inspection, apical impulse is seen in left sixth intercostal space, half inch lateral to mid.
One sec. Go back. You said
Yes,
peripheral pulses are palpable. What all pulses did you look for?
So I looked for radial, ulnar, posterior tibial, dorsalis pedis.
You have a patient with AS. What else will you look for?
And any other peripheral signs associated AR?
That's okay, but what else? In AS specifically you look for? Don't you want to palpate the carotids?
Yes, sir.
What will you get in the carotids? Carotids, you will have a conducted murmur. I mean, conducted this thing. So you will have a thrill or your, on the carotids, right?
Yes, sir.
Carotid is also a pulse, right?
Yes, sir. Yes, sir.
So you have to see there in when you're talking about pulse only. If you're talking about AS, you have to mention systolic thrill in on the carotids, or if it is AR, you have to say peripheral signs of AR in your general examination only.
Okay, sir.
If you have AR, you will have a wide pulse pressure. You will have peripheral signs of AR. But in AS, you have a low systolic this thing, and you will probably have systolic thrill on the carotids. Systolic thrill on the carotids could be due to conducted sound from the valve, or it could be inherent because of some stenosis of the carotids. Yeah. Okay. Next. See what because it's been a long time since you all presented cases, so I'm trying to go through all the basics.
Yes, sir. On a cardiovascular system, on inspection, apical impulse is seen in left sixth intercostal space, half-inch lateral to mid-clavicular line. There were no scars, engorged veins, or chest deformity. There were no pulsation over precordium or chest wall.
What does that tell you? Hold on. Don't go around. This is we are going to analyze every single thing. Apical impulse, yes. Fifth left intercostal space, sixth intercostal space means what to you?
That apical impulse is shifted lateral and downward.
What does that mean to you?
Sir, the LV apex is shifted down, so there is left ventricular hypertrophy.
Cardiomegaly, right?
Yes, sir. Yes, sir.
You have to talk in scientific terms, madam. Cardiomegaly. So is cardiomegaly a common feature of AS?
Yes, sir.
Is it?
I mean, only left ventricular hypertrophy, but if it is associated with any regurgitation, then yes.
Yeah, you have to have a combined lesion. In pure AS, you will not get left ventricular hypertrophy. I mean, left ventricular enlargement. You will have more of a concentric hypertrophy. Yeah. So when the minute you see your apex beat is way shifted way out,
yes, sir.
That means it is you are looking at cardiomegaly. You are having a combined lesion.
Yes, sir. On palpation, apical impulse is confirmed to be in left sixth intercostal space, half-inch lateral to mid-clavicular line. It's heaving in character. There is no palpable heart sound, thrill, or parasternal heave. There is no palpable pulsation over the chest.
What do you mean by heaving? How to define heaving?
The heaving on the, if you place the ulnar aspect of your hand on the left or right parasternal area, if it gets lifted up.
I'm talking about the apex, madam.
Okay, heaving in character.
What do you mean by heaving in character on the apex beat?
It is sustained.
The finger is lifted and it is sustained lift of the finger is heaving.
Yes, sir.
If there is lift and it suddenly goes down, then it is hyperdynamic. If it just touches your finger and goes down, it is tapping.
Tapping.
And or as against a normal apex beat with the other things, right?
Yes, sir.
So tapping means right ventricular hypertrophy. The left ventricle is way down. It just comes and touches the whole finger and goes down. If it is sustained heave, then there is increased timing for the stroke volume. So it lifts the finger and holds there for a little longer time. If it lifts quite high and then goes down quickly, then that is a hyperdynamic apex.
Yes, sir.
And then also parasternal heave. You must know the grading of parasternal heave. How do you grade murmur?
Systolic and diastolic murmurs.
Mm.
Systolic murmur we grade into 6.
Mm. How do you do that? What are the grade 1? What is grade 1, 2, 3, 4?
The grade
See, you're fumbling with these basics, madam. Agreed. In the present situation, you all will look at some echo reports and other things, but you should also know how to do clinical examination. This is what the examiner will ask you in your case presentation.
Yes, sir. So
Grade 1 is barely audible. Grade 2 is audible, well audible.
grade
All right.
3 is well audible. Grade 4 is associated with a thrill. Grade 5 is just at the, if we just keep the diaphragm of the stethoscope on the chest wall, we'll know. And grade 6 is even just away from the chest wall.
So you must know grading of the murmur. There was no thrill or no this thing on palpation. Oh, okay, fine.
No.
We are in palpation. Fine, all right. No palpable pulsation over the chest. Okay. Next.
Auscultation. S1 is normal. S2 is soft.
You 1 minute. Nowadays, people don't think about percussion to be important, but you must know how to do percussion and what is the relevance of doing percussion on the heart.
Okay, sir.
At least theoretically, you should know whether you do it or not. Is why do you do percussion of the heart? I mean, the precordial.
With
One
percussion, we
to decide whether there is cardiomegaly or not, whether the left heart border is away from the normal or the right heart border is away from the normal. Both of them have their relevance. Understand?
Yes, sir.
So you must know how to percuss for the right heart border and how to percuss for the left heart border.
Okay, sir.
Do you know how to do that?
Yes, sir. So
Tell me, how do you percuss the right heart border?
For the right heart border, I'll come from the right parasternal area.
No.
Below the vocal till.
No, not right parasternal area. You have to come from somewhere else. See, that is why I want to know. I want you all to know. You will percuss from the second space in the mid-clavicular line down to the liver dullness. Then one space above, you will turn from, in that space, you will go from lateral to medial till you get the dullness. That is the right heart border. Okay. And the left heart border, you palpate the apex, one space above, come from the axilla down in that space till you get the dullness. That is the left heart border. And maybe in the second or third space, lateral to medial, that will tell you the pulmonary segment. So these are things that you have to know. And if there is cardiomegaly, then that is corroboration of a increased volume in the ventricle. So it is a volume overloaded ventricle. So it could be MR or AR. Mitral stenosis and aortic stenosis classically have smaller LV. Okay. Or if there is a congenital heart, there will be a massive enlargement of the. So the right side is also the right border of the heart is grossly enlarged. So it will be something like an Epstein. If there is bilateral enlargement, so it could be a pericardial effusion or a multivalvular heart disease, as in rheumatic heart disease, MSMR, ASAL. Okay.
Yes, sir. Yes, sir.
So percussion, don't forget, if the examiner asks you, you will have to do. So as a routine, you people should know how to do a percussion and then keep it. So whether the examiner asks or not, it's okay. You can just mention, or by percussion there is some amount of cardiomegaly seen. Boom, the left heart border is shifted outwards in this patient. Okay.
Okay, sir.
So maybe in the present day, people may not give a lot of importance to the percussion. However, clinical examination you should be able to tell whether there is cardiomegaly or not. Otherwise, the standard thing for cardiomegaly would be on the X-ray and the dimensions on the echo. Okay.
On auscultation, first heart sound is normal. Second heart sound is soft. A harsh crescent or decrescent or ejection systolic murmur of grade 3/6 is heard in the aortic area, which is best heard in expiration. The patient sitting and leaning forward position, which is heard with the diaphragm of the stethoscope. It is radiating to bilateral carotids. No other murmurs are.
No, hold on. This best heard in expiration is only meant for AR, early diastolic murmur. Systolic murmur, you don't have to do all this circus. Understand?
Yes, sir.
The best heard in patient leaning forward in expiration is only for early diastolic murmur. Systolic murmur doesn't require that. Okay. Second, leaning forward, heard with the diaphragm of the and radiating. What is the difference between radiation and conduction?
The radiation is in series.
No,
the murmur
is the other way around. Conduction is in the direction of the flow of the vessel of the blood. So from LV aortic ascending aorta and then into carotids, that is in the flow in the same direction. That is conduction. Radiating is you hear a murmur in the apex, and you also hear the same murmur in the axilla or in the back. That is radiation. Okay.
Okay. This is conducting to bilateral carotids.
This is conduction to bilateral carotids. So you must understand this subtle difference in the terminology. No other murmurs heard. Okay. What other murmurs would you expect? In this patient, you would probably expect a pansystolic murmur of MR or a early diastolic murmur of AR, because your left ventricle is enlarged.
Yes, sir.
Downward and outward displacement of the apex, which is unusual in a AS, pure AS patient. Okay.
Okay, sir.
See how much of this thing you have missed in your clinical examination. Okay, next.
Other system examination, respiratory system, bilateral normal vesicular breath sounds here. There are no added sounds. Per abdomen is soft, not tender, no organomegaly. Central nervous system, higher motor functions and sensory systems normal, no focal neurological deficit. A provisional diagnosis. The 63-year-old gentleman with severe aortic stenosis without features of congestive cardiac failure, thromboembolic episodes, and effective endocarditis, who's in sinus rhythm, probably of degenerative etiology.
That should have come earlier. Severe AS of degenerative etiology without all these things. Okay. Why do you call it degenerative?
Based on his age.
And no previous history of any.
No previous history or no family history also.
So how often do you get history of rheumatic fever in a patient?
So only 25% of people give.
Not 25, 50%. 50% will have history of rheumatic fever. 50% will not give you a history of rheumatic fever. Okay.
Yes.
And why do you call this severe?
So because
You
of
don't. What are the features of severity of AS?
so this pulsus parvis et tardis, this increased harshness of murmur, soft S2.
Increased harshness is not allowed. Severe AS, you will have a thrill.
Thrill is not there, but this late peaking of murmur.
Oh, that is subjective.
Yes.
What is this Borosil lunchbox? Okay. So subjective. Your moderate, your peaking or your this thing may be different from what I feel. So it should be uniform. So if there is a thrill, then there is severity. If there is
Yes.
delayed peaking, yes, again that is also subjective. So all right, we will take it as this thing. Okay, we'll call it severe. We will know by other criteria whether it is severe or not. Okay. But generally, if you have a thrill, then that is severe. If you
Yes.
don't have a thrill, then you can say moderate to severe. You can sit on the wall. Okay.
Yes, sir.
Conduction to carotids, thrill over the carotids, and thrill on the aortic area will say that this is clinically a severe AS. Again, with the symptoms, this person has no classical symptoms of AS at all. He only had giddiness.
Yes, sir.
Otherwise, the classical symptoms for severity of AS would be starts with angina, then syncope, and then heart failure. If a patient has heart failure, it is very advanced level. There is already decompensation of the LV. So symptom wise, he doesn't have severe features.
Yes.
Clinically equivocal. Okay.
Okay. Yes, sir.
So clinically, you can still say moderate to severe AS. All right, because you're not sure. If you have these things, patient has had a history of angina, which has progressed to syncope, which has progressed to heart failure, and then you have a long murmur with a delayed peaking and soft AS, A2, and reverse splitting. That is another feature. A2 and P2 comes together. A2 comes earlier than P2. If you have A2 coming after P2, that means it is reverse splitting of the second sound. So that is again a feature of severity clinically. Okay.
Yes,
So
sir.
these are things. Now, ultimately, finally, you will decide. You will say, why, sir? All these things. We will decide on the echo or CAT. This thing. But unfortunately, these are things that are traditionally asked in the exam, and you have to know. Agreed. In the present day and this thing, most of the decisions is based on the echo, right?
Yes, sir.
Okay. Now, what are you going to do?
I would like to further investigate and confirm the diagnosis to decide on further management.
What investigations are you doing, and to confirm what and to rule out what?
This is an ECG, 12-lead standardized ECG.
You will do the investigations to corroborate your diagnosis of AS, severe AS, and also to rule out other valvular heart disease valvular involvement, right?
Yes, sir.
You have to rule out AR. You have to rule out mitral valve disease. Okay. What does this ECG show?
Yeah, this is a 12-lead
what would you expect in ECG in AS, severe AS?
So I would expect sinus rhythm, with a left axis deviation with a left ventricular hypertrophy.
Is it there?
So yeah, it is there, sir. It's a normal rate, regular rhythm in sinus, left axis deviation with left ventricular hypertrophy.
What criteria?
The Sokolov line criteria, but the R in AVL is more than 11 mm.
Yeah, but S and V5, R in S and S and V5 or S and V2 and R and V5 is not. It
35,
doesn't look
but the
like
other
that.
criteria is R in AVL more than 11 mm. That is there.
There's only one single criteria, and that I don't think that is relevant. What else would you look for in AS as against AR? You have to know whether it's a pressure overload or a volume overload.
So the LV strain pattern.
Where is the LV strain pattern? I don't see
Here
LV
it is
strain.
not there. Here it is not there.
So none of the features of AR, severe AS is there on the ECG.
Yes, sir.
So it does not corroborate your diagnosis. There is no pressure overload. There are no definite features of LVH either by any of the criteria, standard criteria. There is no strain pattern, right?
Yes, sir.
So it does not support your diagnosis. Okay, next.
The chest X-ray. Well centralized, well exposed. Trachea is in midline. And there is a cardiomegaly. Aortic knuckle is prominent. And other than that, there is a post-stenotic dilatation of aorta.
I am not too sure. I don't see that. Anyway, sure. Can you trace the ascending aorta with your?
Yes,
It's with your phone, huh?
Yes, sir.
Okay. It is not really so much. Why do you get a prominent aortic knuckle? What in AS you will get a post-stenotic dilatation. It is not very well seen because the right heart border is not so much enlarged, nor can I see an unfolding of the ascending aorta. And then aortic knuckle. Is he a hypertensive? No, his blood pressure was 108 or something.
Yes, sir. No, not a hypertensive.
Okay.
LV apex. Then the lung parenchyma looks normal. CP angles are clear. And other bony structures are normal.
Looking at this X-ray, it feels like this patient has had prolonged history of hypertension, but now his blood pressure is low. What does that indicate to you?
So he's on clinidipine also on treatment for past 6 months.
He's on treatment. Okay, one maybe. Second, blood pressure is low. He may be already on decompensation of the LV.
Yes, sir.
Maybe. I mean, you'll have to think on all these lines because that makes important decision making and also the prognostic value of your surgical procedure. High gradient EF with normal EF and low gradient with reduced EF. All right.
Yes, sir.
So that tells you the severity of LV dysfunction and your outcome after an AVR. All these things should go through your mind because you're going for your final exam All these things will be asked. It's good to know all these. Okay.
Yes, sir.
Just presenting a case for AS, okay, they've got the murmur, AS murmur and things like that is okay for the second year people who are going for exam. But at your stage, you have to learn, you have to know what to do, what is the assessment, pre-op assessment, how do you do your AVR, what is the things, what are the things that you will expect post-operative period, what are the problems that can happen. All that will be discussed at your stage. Okay, X-ray is showing cardiomegaly, X-ray is showing well, the ascending aortic dilatation is not very clear anyway. This also does not corroborate your clinical diagnosis. Okay.
Yeah. Echocardiography, a transthoracic echo. This shows significant aortic stenosis and a bicuspid aortic valve with a mild to moderate AR. The aortic valve is bicuspid with raphe, anteroposterior asymmetrical cusp, heavily calcified with restricted mobility. The gradient across the valve is 56/27 with a mild to moderate AR. And yes, sir, mild to moderate AR.
So you missed the whole AR completely in your clinical examination. Okay, this is where your clinical examination of leaning forward, breath held in expiration is important. And you were not able to hear any diastolic murmur.
No, sir, it's mild to moderate AR.
You did say that in your examination. You only mentioned about AS.
Yes,
okay, and then
systolic
what is the gradient on the aortic valve?
56/27, sir.
56/27. So on criteria, what does it fall into? Mild, moderate, severe, AS.
Moderate, sir.
What is the peak gradient?
Peak gradient is less than 36 is mild, 36 to 64 is moderate, more than 64 is severe.
Okay. What are the LV dimensions?
So the end diastolic volume is 125, end systolic volume is 44 ml, and the left ventricular internal diameter in diastole is 47 mm, and during systole is 31. And the interventricular septal diameter is 13, and posterior wall diameter is 10 mm.
And then there is global
hyperkinesia of ventricle.
The LV, no LV thrombus. So thickened leaflets, posterior mitral is okay, prolapsed MR, mild to moderate MR. Aortic
And aortic annulus is 23 mm, the sinus is 41 mm, the ascending aorta is 40 mm. The other valves only mitral has mild to moderate MR, mitral valve prolapse is there. Tricuspid is okay. And chamber dimensions, the left atrium is 40 mm. And with the LV dimensions is mild left ventricular hypertrophy is there. With the normal RV function, TAPSE of 21, and the left ventricular function is ejection fraction is 40%.
LVF 40%. Earlier you said 55 somewhere?
No, so here it's 40% they have mentioned.
Oh, previous echo. Okay. Previous echo showed 55, now it is 40. All right.
Yes.
So what is the final impression?
Final impression is moderate aortic stenosis, a bicuspid valve with an associated mild to moderate AR with a mildly dilated ascending aorta.
And?
With a low ejection fraction.
Okay, and? You didn't say anything about the mitral valve. Are you going to address the mitral valve or not? In your surgery?
No, sir. No, sir. It's A to P2 is only mildly prolapsed with a mild to moderate MR. So on table transesophageal echo I'll do. If it is not significant, we'll not address it.
Okay. So what is your surgical? What is your management? I don't know. what you got to do?
That I like to do a coronary angiogram.
Okay.
So his coronary angiogram is normal, sir. Only mild, minor plaquing is there in the right side, insignificant disease.
Okay.
Then I would like to suggest him to undergo a surgical aortic valve replacement with a mechanical bileaflet valve.
Why mechanical? Why surgical?
So,
Why not TAVI? Why not TAVI? That is the fashion of the day.
no, sir, he is fit enough for surgery.
What is the contraindication for TAVI here?
So he's fit for surgery with no major comorbidities contraindicated to surgery.
He's got a bicuspid aortic valve, madam.
Yes.
So surgical AVR is better in this situation, isn't it?
Yes, sir. Yes, sir.
You must say that as the first thing. He's got a bicuspid aortic valve and is fit for surgery. Fine. So you would do a surgical AVR. But why mechanical valve? He's 63 years old.
Yes, sir. He's 63.
But
Less than 64
if you put a mechanical valve, he'll require anticoagulation.
Yes, sir. There's no contraindication for him, and he's less than 65 years old.
Hmm.
It's a gray area, 60 to 65.
So why mechanical valve?
Sir,
Nowadays
biological.
you nowadays your tissue valves are being claimed to get 20-25 years life.
But nowadays, whatever we have seen, all the biological valves are coming in 3 to 5 years with dysfunction.
But your all the biological valve manufacturers claim 15 to 20 years life.
Yeah,
That
but whatever we see, it's like mostly like 80% of people are just coming back within 5 years.
okay. 80% come back in 5 years.
Yeah,
Wow.
so most of them.
That's a major this thing. Somebody has done a study. I think you should do a study on that.
Yes.
That goes against the literature. Yeah.
Yes, sir.
Okay. Now coming to the choice of valve. Yeah, you can argue either way, but basically this patient is 65. Is he still active as a farmer or not? No.
Yeah, he's working.
He's working. He's working.
Yes.
But after surgery, I don't think many of them will go back to work anyway. That is another thing. So he's still working. He's still active. Then he will need an anticoagulation. He will be prone for injuries. So he would be probably be better off if you want to do a tissue valve. I'm just playing the devil's advocate. Okay. I'm trying to make you think. I'm trying to make you think so that whatever you choose, ultimately, you must justify your choice of the valve. Understand? If you're going to use a mechanical valve, fine. You can use a mechanical valve. There's no hard and fast this thing. But you have to justify why you are using a mechanical valve. If you're using a tissue valve, you must know why you are using a tissue. Follow?
Yes, sir.
Either way, you have to convince your examiner what you choose is the right thing to do. Okay?
Okay, sir.
All
so
right.
ideally,
Now,
I should.
what?
Valve.
Huh?
Should I tell bioprosthetic valve as the first preference?
Well, depending on because he's 65 already. If I was around 50 or so, I would have accepted a mechanical valve. But if he's 65 and then the normal life history of lifespan of somebody would be around 70, 75, or maybe even if it is longer. And then what is the long-term result or long-term survival of after an AVR? Do you know?
And it is 88% in 10 years.
So around 10-year survival is pretty good.
Yes, sir.
Whereas a double valve, the 5-year survival itself is suspect. Okay. So in AVR, you'll at least get a 10-year survival. So you should be fine.
Mm.
So you have to argue. If I'm the examiner, I will object to a 65-year-old fellow going on anticoagulant who is still an active farmer. I would probably say no, is not fit for a mechanical valve. But there may be other people who will say that, okay, no, he's still fine. And as you rightly are, probably, I don't know how much you have to corroborate with your statistics. If you are going for the exam, you have to have statistics in saying that 80%, 5-year survival, 5-year, many people, 80% are coming back with the valve derangement. There may be some other causes for that. Okay.
Okay, sir.
So whose patient is this?
Ravindra Shetty, sir.
So Ravindra is away, but when you have to discuss with the surgical consultant now and then go back, sir, why are we using, what are we using, and things like that. On table, you have to discuss these things, the choice of valve, and then what you're going to do. All right.
Yes, in
This
his
is how
OPD sheet, like in his outpatient sheet, he has mentioned his advised Chitra valve for this patient.
okay. Chitra valve, probably because of cost factor now.
Yes, sir. Yeah.
That is another different issue. If you that may be the reason why he's asking for a Chitra valve. Okay. So you must check with the consultant later on, find out, sir, what is the why are we using a mechanical valve in this patient? You put forth your arguments like this. Whatever this patient is going to be 65. He's going to be active still as a farmer. You can avoid anticoagulation. All these things. So you have to get his opinion as well. Okay.
Okay.
He may have different opinions. Okay, we are already 8:30, almost close to 8:30. What are the important things that you will face during your surgery? What is your you will do minimal invasive AVR, you will do standard AVR, you will do
standard
what cannulation you will do? Why not minimal invasive?
Sir,
Just excuse me for 1 minute, okay? I'll be back.
Yeah.
Okay, sorry about that.
Yes, sir.
Now, when you're talking about AVR, you must, in the present day, in our days, it was okay. It was everything by median sternotomy, so it was all right. Now you must know when to use a minimal invasive or a partial sternotomy or a full sternotomy. What are the measurements that you take to choose which approach? All right.
Yes, sir.
So what are the criteria for minimal invasive approach? What are the things that you need to know? The ascending aorta, how far it is from the midline, what is the orientation of the valve? All these things matter for minimal invasive approach. Whether you're going to do upper partial sternotomy or a third space, fourth space intercostal approach. All right.
Yes, sir.
And then median sternotomy. So you, at your stage, probably you are safer to say, okay, sir, in my experience, I will do a full-fledged median sternotomy. Fine, acceptable. So what is your cannulation strategy?
So I'll go aortic and two-staged venous right atrial cannulation, and I'll put an RSPV vent. Then once heparinized and cannulated, then I'll take a marker stitch on aorta about 1 centimeter above the origin of RCA.
And
Then
what temperature? What temperature you're going to use in your CPB?
I'll tell them to cool to 32.
Yeah.
32 degrees.
You will not cool before putting in an RSPV vent. Okay.
Yes.
This
Yes,
patient has AR as well. So once you start cooling, he will end up with the fibrillation
yes,
and distension of the LV. So you must have an RSPV vent, and then only you will tell your perfusions to start cooling.
yes, sir.
Okay, 32 is fine. All right. Then
Then I'll confirm ACT to be more than 480. Then I'll go frontal and back position and go on bypass. And then achieve once a good drainage is achieved, I'll tell them to start cooling. Then I'll prepare and de-add the cardioplegia. Switch off the ventilation. The RSPV vent will be turned on. After that, I'll
what's
get the.
What's your cardioplegia delivery?
I'll use delnido cardioplegia, 20 ml per kg body weight.
How will you give it?
So this one I'll do an iototomy and give direct osteal cardioplegia.
Correct. Okay. Why?
Because of AR, associated AR is there.
So he's got AR. All right. Okay. Borderline LV function. So you would probably give direct through the coronary ostia. Fine. You must know that. Okay.
Yes, sir.
So you cannot give it through the root. All right. Fine. Okay. Cardioplegia done. This thing. Then what will you do?
Yeah, I clamped and given a direct plegia. Then for surface cooling, I'll apply ice slush. Then I'll take stay sutures on the aortic wall and keep it retracted. Then I'll inspect the valve.
How will you do your aortotomy?
Sorry, sir. Transverse aortotomy.
What is the aortic annulus on the echo? You didn't tell me that.
23 mm, sir. 23 mm.
23.
23
okay.
mm.
Okay. All right. So you don't need a root widening. So you will do a transverse aortotomy. Fine. Okay.
Yes, sir.
Then
I'll start excising the valve. I'll start with the right coronary cusp. Excise the aortic valve, leaving a 1 mm margin.
Excuse me, madam. This is a bicuspid valve. What do you mean by
sir.
right coronary cusp?
From the right side.
Yeah. Don't keep on saying something just like a parrot from the book or whatever. You have to talk things relevant to this patient. This is a bicuspid valve first. All right. And then you will look for whether there are any calcification. If there are calcification, what precautions you are going to take. All right. You will look at
Yes.
because in a bicuspid valve, you have to look at the coronary orifices. They may be malpositioned.
Hmm.
Uh, all these
Yes.
things you have to mention. If you say all that, then the examiner will straight away say, okay, you know what you're doing. You are a safe surgeon, and then you have better chances of passing straight away.
Yes. I'll excise the cusp, and before removing the calcium, I'll put a gauze, wet gauze inside the LV.
Mm.
And coronaries also I'll protect, and using the Ronchar, I'll remove the calcium.
Mm.
Then once
If there are calcium, you may be there, may not be there. But since it is a bicuspid, long-standing bicuspid valve, more likely that he will have some amount of calcium there. He's a 65-year-old man. Okay.
even an echo they mentioned it's heavily
Yeah.
calcium.
So then, yeah.
Then
Oh,
once
echo
the
said.
valve,
Hmm.
yeah, echo.
Hmm.
Then once the valve is excised, I'll size the valve. Then I'll give a thorough saline wash
Hmm.
using an outside suction. Then I'll remove the gauze.
Hmm.
Then I'll take an appropriate sized valve and use
Which valve are you
two.
doing now? Which valve are you doing?
So now I'm doing bileaflet mechanical valve.
Bileaflet mechanical. Okay. What is your orientation of that valve?
So the large orifice towards the left ostia, coronary ostia.
Which one?
The the what the what is it? The opening orifices
Hmm.
is towards the ostia, coronary ostia.
Okay. So it will be horizontally oriented
Yes, sir.
so that the orifices are opening into the two coronary ostia if they are opposite each other.
Then, yeah, in normal position.
If they are not,
Then accordingly we have to tilt the valve.
turn the valve. Okay. Supposing you wanting to do a Chitra valve, what will you do?
Chitra valve that I'll position in such a way that the greater orifice is towards the ostia.
Towards the?
Coronary.
No. No. The greater orifice will be placed because it's a single tilting disc valve, isn't it, Chitra?
Yes, sir.
So the greater orifice will open along the line of the ascending aorta for a single tilting disc valve, isn't it? What, madam? The greater
Sir.
orifice opens against the ascending aorta in the line of the flow of the blood.
Yes, sir.
See, this is important. And in a bicuspid valve, you have to know what is the difference between a tricuspid valve and a bicuspid valve, the valve orientation. In a single tilting disc, it doesn't matter because it's always against the ascending aorta. The greater orifice goes towards the ascending aorta. But if you're using a bioprosthetic in a bicuspid valve, because you don't see the commissures, right? So you must know how to orient them. So these are things that you have to go back and read.
Okay, okay.
How do you orient a tri-leaflet bioprosthetic in a bicuspid aortic valve? Yeah.
Yes, sir.
And
Yes, sir.
how will you orient a bileaflet in a bicuspid aortic valve? Depending on the site of the coronary orifices. These are subtle things that they will ask you in the exam. Because if your orientation of the valve is not proper, it will not function. One, there will be coronary ostial obstruction, and second, it will not function very well. You follow?
Yes, sir. Yes, sir.
And then 23 mm annulus size, you should be able to put in a standard size valve with the standard suturing. What sort of suturing are you going to use?
So I'll use 2 ethibond interrupted stitches.
2O.
2 or 17 mm.
Huh?
2 or 17 mm for aortic.
Interrupted.
Yes, interrupted sutures.
Will you use a pledget or no pledget?
Sir, nowadays without pledgets we are using.
Okay. So that means you have to use, how many sutures will you use on an average?
12 to 14 sutures.
That may not be enough for us. Interrupted simple sutures. Interrupted simple or mattress?
Mattress, sir, mattress sutures.
Mattress sutures without pledget. Nowadays you don't use pledget. Huh?
I mean, still some consultants use, some consultants don't use.
Okay. What will you use?
Sir, without pledgets.
You're a bold surgeon. You will have paravalvular leak after you tighten it tightly. You will have one of those sutures will give way. Then what will you do?
No, sir. If the annulus is the aortic annulus is weakened, then I'll use pledgets. If it is not, if it is healthy, then without pledgets I can go ahead.
Well, okay, but I would probably be safer to say pledgeted interrupted sutures. In a normal size valve, 23 mm valve will be easily seated with a pledgeted suture through the aortic side and through the valve, right? That would be safer. Otherwise, it will cut through, and then this. There are some people who will use continuous suture with Prolene, or there will be some some people will use only interrupted simple sutures, depending on the choice and the way they have been trained. You must have.
Yes, sir.
So when will you? All right.
Yes, sir.
So, all right. But the basics of clinical examination should not to do space intercostal approach. All these things matter.